Can we have that first slide, please? Good afternoon, ladies and gentlemen. Welcome to this course on the ocular surface disorders. And we're going to try with Quresh and Dr. Vanathi and Rajesh and Rohit to try and clear up some of the latest that's on in this area, as well as if there are any confusions, discuss the changing paradigms. And that's really the course. So we've been doing this now for a few years at the AIOC. And it's evolved, and as you will see, there's a little bit of an evolution that happens each time we have something new developing. We also have new things being discussed in this course. So can I go on to the next slide, please? So this is what the structure of this course is going to be. We'll start with having Dr. Maskati tell us about what's really troubling the patient from a clinical point of view. Then we'll see how there are other areas or other aspects of the ocular surface disorders which mimic the dry eye and discuss those. And then Dr. Vanathi will be talking about how to choose an appropriate artificial tears and the conventional management of dry eye syndrome. Dr. Rohit Shetty is going to be telling us about the role of vitamin D and how the inflammation is coming up in a big way in ocular surface disease. I'll then be talking about the hyperosmolarity and osmoprotection, something that's been there now for close to a decade, but it's still something that we haven't all got hold of yet. And then Dr. Rajesh Sinha is going to come up with 3 small talks. First on Meibomian Gland Dysfunction, the second on a new paradigm called OHHQ and the post-surgical dry eye, and then talk about topical chloroquin, which is a newer molecule which is available for dry eye disease. Dr. Vanathi will then complete, along with Dr. Maskati, the talk on Cyclosporin and how effective it is and what's the latest on Cyclosporin. And then Rebamipide, which is a new product which is available now to us. And that would then conclude. And we will then have a panel discussion as well as answer questions from the audience. And if there's anything at all, just feel free to ask us. It is an instruction course in the end, so we like it to be interactive as much as possible. So just raise your hands, and even if it's in the middle, I don't mind at least. Even if it's in the middle, there's something that you'd like us to elaborate on, please just interrupt us, no problems. Next slide, please. We will, of course, initiate proceedings with our honored guest, who will be delivering a keynote address on the therapeutic use of scleral contact lenses. And please welcome Dr. Mark Rosenblatt, who is the professor and the head of department at the Illinois Eye and Ear Infirmary at the University of Chicago. Dr. Rosenblatt, please.
Thank you so much. It's really a pleasure to be here. I want to thank the organizers for inviting me and also, of course, for being so hospitable. It's really a beautiful conference and really infused with a very special culture. I appreciate that. I hope that my talk isn't like OSD and is neither concerning or confusing, but hopefully it'll make a few things clear. This is an area that is of great interest to us in Chicago, but I think also has a great deal of interest here in India as well. It's use of scleral contact lenses to treat ocular surface disease. These are my disclosures. None of them are relevant to this talk. So scleral lenses are important that they don't touch the cornea. Essentially, a fluid reservoir is contained within the space between the cornea and the lens, and therefore leaves the cornea unperturbed. And on the right, you can see a diagram where you have haptics which touch the scleral portion, hopefully clear the limbal region, and then vault over any ocular pathology. And beneath this vault is this refreshing liquid that should keep the cornea in a pristine state. This idea of scleral lenses aren't new. Leonardo da Vinci, like he thought of many things before many other people, thought of these kinds of lenses in the 16th century. And over time, there were various iterations of scleral lenses. I won't go into the details, but currently there are dozens of types of scleral lenses. I think there's even some originating here in India that are very special. So although I'm going to talk about one particular type of lens primarily, which is the PROS lens, which stands for prosthetic replacement of the ocular surface ecosystem, which is sort of the most customizable version of the lens. Most of the things I'm talking about are actually relevant to all types of scleral lenses, so that's an important element. So the PROS lens was developed at Boston Foundation for Sight It's fluid ventilated. It has a unique liquid corneal bandage. It has diameters ranging from about over 17 to up to 23 millimeters, high decay, and there are about 12 sites in the US that fit these lenses, and I believe 3 here in India that are able to make these lenses. And the lenses are highly customizable. There are many different free parameters. You use computer-aided design software. But much like a suit, I actually need a tailored suit to even look half decent, but many of you can buy suits off the rack and look great, so not everyone needs a pros lens to have the therapeutic benefits of a scleral contact lens. So the 2 indications, went forward here a little bit, the 2 primary indications are corneal irregularity or ocular surface disease. And so Perry Rosenthal, who is sort of the father of the Boston scleral lens, did some studies and published a large series of patients looking at all the different myriad clinical indications. These can include corneal degenerations like ectasia, corneal dystrophies, other things that cause ocular surface irregularity, including aphakia or myopia. And all of these are useful uses of the corneal irregularity aspects of the scleral lens. And probably most importantly for this session is the use in ocular surface disease, including corneal stem cell disorders like Stevens-Johnson syndrome, OCP, neurotrophic conditions. We use it quite a bit in ocular graft versus host disease in our institution, and other types of severe ocular surface disease that aren't amenable to other therapies. And so the outcomes are quite good. If you look at improvement in visual acuity, almost all patients who are able to tolerate the PROS devices ultimately have improved acuity, but also importantly, when you look at the VFQ-25 function, they see better, they have less pain, and their overall mental health is improved. So these can actually, and their dependency upon others decreases as well. So here's some examples. A man with keratoconus, 56-year-old, can't wear his contact lenses even though the contact lenses give him good vision because atopy. By putting on the contact lens, it shows that he has keratoconus. You see there's a nice vault. There's an area of fluid underneath the lens between the cornea and the scleral lens, and he's now able to tolerate the contact lens because the lens forms a shield against the environment in the lids, creates an expanded tear reservoir. So he's able to have 20/20 vision and now tolerate this kind of contact lens. A patient with Stevens-Johnson syndrome, 29-year-old man with Stevens-Johnson syndrome from age 9. Bilateral buccal grafts, but now has tried every sort of topical medications on frequent anti-inflammatories, frequent artificial tears, but still has visual acuity of 2400 and count fingers. You can see there are sort of typical findings for limbal stem cell deficiency and opacities after this very serious disease. But after getting a good fit with a PROS device, he's able to be comfortable, he's able to wear the devices, and more importantly, his acuity initially improved to 20/21/5 and 2200, but later further improved to 20/70 and 2100. So you're not just